Hi, this is Dr. Sridhar Daima. I am back with new video. This is laparoscopic surgery for clearance of endometriosis along with adenomyomectomy to enhance the fertility. As you can see, the right ovary is adherent in the ovarian fossa and to the rectum, and there is a disturbance in the tubo-ovarian relationship. After the release of these congenital sigmoid adhesions, ureter is identified at the pelvic brim and peritoneal cut is taken. Ureteric peristaltic activity is seen nicely. Right ovary is lifted up and released from the ovarian fossa, and also this is made free from the rectal fat medially. Injection vasopressin is infiltrated in its diluted form into the ovarian ligament, and then we proceed for the ovarian cystectomy. As the cyst is small and it is mostly projecting out of the ovarian substance, it is easy to peel it off. One more very small endometriotic cyst is seen, and that is also excised. Ovarian reconstruction is done with the absorbable suture material, and the same suture is used for the temporary ovarian hitching to the anterior abdominal wall. This saves a lot of time and gives a good surgical exposure. Coming back to the ureterolysis where we left it, it is continued and the ureteric tunnel is reached. There is a nice crossing of uterine artery and the ureter. The normal anatomy is seen very nicely. Medial pararectal space dissection is done distally because there is no major pathology in the proximal part. Traction and the counter traction is essential to navigate into the proper plane. Similar steps are performed on the right side. Now rectum is released completely to enter into the rectovaginal space. Inflamed uterosacral ligament is cut excised after safeguarding the ureter and the inferior hypogastric nerve. Disease of the torus is also cut excised. Torus is the region which is posterior to the cervix, and this is considered to be the epicenter of the disease in most of the cases. The ovary and the torus, these are the very common areas of the proliferation of the endometriosis. Small endometriotic deposits around the ovarian ligament, they are noted, and ovarian ligament is skeletonized, and afterwards this nodularity will also be excised. Small implants on the vagina, they are also cut excised. Small pathological peritoneal implants around the ovarian fossa, they are identified, and this peritoneum is stripped off from the underlying structures. These small areas are often missed during this surgery. Now, nodules over the rectal fat is taken care of. The rectal shaving is mainly dependent on your palpation findings. You have to go deep enough till you feel the normal supple areas of the rectal wall. In the next part, we move towards the adenomyomectomy. So we take the transverse incision over the posterior wall of the uterus near the fundus, and this incision is deepened till few centimeter till we traverse through the adenomyotic tissue. One can appreciate the amount of hardness in the consistency is appreciable. Then the vertical incision is taken. So basically the posterior wall of the uterus is open in the three flaps, and with this exposure adenomyotic tissue is taken care, is cut excised from the core with the harmonic. One should remember that we have to maintain at least 0.5 centimeter of the serosal wall to achieve good reconstruction afterwards. There is a particular way of adenomyoma bed reconstruction. The three flaps are not just approximated, rather they are overlapped on each other. For that, one flap, that is lower and right sided flap, is sutured to the adenomyoma bed. For this adenomyoma suturing, barb suture is used in a particular manner. And once one flap is sutured, the second flap is taken and overlapping is achieved. This overlapping provides better strength to the wound and better healing, and it decreases the chances of uterine rupture in the future pregnancy. Indigenous endobag is used for the specimen extraction. And this is the end picture at the end of the surgery, where there is a complete clearance of the pathological tissue.